Stop running.
Yeah, that's it.
All right, thank you all for coming. Really good to see so many people here. This is our third event of this nature. We've had some really good engagement from people and really glad to see so many people joining us. We're setting these up as kind of Midlands region improvements, learning and sharing kind of events from the data team. We're really lucky today to have Holly and Jenny joining us from the central team who kind of produce the RightCare population, the RightCare primary care network packs, which are really useful. They're going to talk through us today. So that's, if you're not expecting to be at that meeting, you're in the wrong place. This is our third meeting. We're following on from doing one on population health component of the model health system, where we had quite a good attendance, and a lot of people asked about getting down to primary care network and practice level. So that's what we're going to try and cover today. Apologies for anybody who's kind of joined, thought kind of this is mandatory, or a bit confused as to why the Midlands region is sending you invitations. We've sent out these invitations off the back of the previous ones, which went a bit more wider than the region. So that's why there's some people from Cornwall and stuff, but you're all very, very welcome to join us. If you want any follow-up and system support, please kind of link you into your local teams. Only kind of Midlands colleagues have got on this call, but you're very welcome to be with us. We've recorded this session, started recording the session. We'll stick this on YouTube if that's okay. If anybody has complaints with that or wants to kind of turn cameras off, things like that as a result, please do so now, or let me know. We can kind of try and do something about that. So we're kind of keen to build on the momentum of this engagement. It's really good to have so many people here with interest in our data. Kim's joined us, who's doing some work on how we build on all this kind of engagement in the region. So we might kind of use this mailing list to kind of invite people to something in the future. So there's things in the pipeline about how do we kind of build this into a more informal network. But yeah, we're here to talk about primary care network packs. Holly and Mona, you have an agenda. I'm going to take through this in detail, but I've been using these packs with systems for a while in the region. Miles might want to say a few words on how these are useful as we go through. They're a very, very comprehensive and useful product that go into fascinating amounts of detail, breaking data down to practice level, and tell us about most of the main pathways we should be interested in as commissioners or people involved in the design of systems. They haven't been broadcast or pushed or widely shared to primary care networks, which is partly because we don't want to overwhelm the audience. But I think Holly will probably describe how we get access to them and make sure they're used appropriately. The really detailed pack, and I think that's to be kind of, we'll go through them and see the length of the volume of data that's in them, but please don't be daunted. So hopefully they kind of give a bit of structure and guide you through, which is what we're going to try and get to today. Mona, do you want to put up the agenda, and then I'll let Holly and colleagues from the central team invite themselves. Final thing to say is, if you've got any questions, stick them on the chat as usual with a Teams meeting, or raise your hand. We'll try and break through out of this to do kind of usual interruptions and kind of find appropriate times for questions. And yeah, that's it. Hopefully it'll be a good afternoon. Has anybody got any questions before we start as well, I should ask? No, okay, if not, that's over to you, Mona, to take us through the agenda, and then Holly, you can take us through the content.
Yeah. Yeah, as Alex has alluded to, and thank you to everybody who's joined this afternoon. So the webinar this afternoon is just going to cover an overview as per the agenda items that were sent out as part of the registration, looking at the opportunities that are available within the PCN packs in terms of quality outcomes, spend and activity measures, how the packs link together with the information that's available with them, some of the data sources that go into producing those packs, how those packs are produced, and the data sources that are going to produce those packs. And also just to outline and highlight the opportunities available within those packs and how to use them within the system. And with that in mind, I'm going to hand across to Holly and Jennifer, who will take you through in detail some of those agenda items that you can see on screen right now. Thank you.
Great, thank you very much. So I will just share my screen. Great. So yeah, hi everyone. So yeah, I'm Holly Davis. I am a senior analyst in the central RightCare team. and one of my main roles within the team is leading on the PCM packs. And so, as both Alex and Mona mentioned, we've also got Jenny Slater joining us today. So Jenny is a colleague of mine who works in the same team, and where I lead on the PCM packs as a whole, Jenny has produced the code and actually produced the packs. So if there's any more, I'm going to briefly kind of go through how the packs are produced later on in the presentation. But if there's any more technical questions, then we have Jenny here to help answer those. So yeah, I mean, Mona's gone through this, but just a bit of an overview of what I'm going to cover. So I'm going to go over the main PCM packs, CCG summary packs, and the STP summary packs. And I'm going to go through each of the charts that are in those packs and how to interpret those charts and how to pull information from them. Also going to go through the kind of why each of the three packs are important and what information they present, and also how to link those three packs. I'm also going to cover the differences between the 1920 packs and the previous 1718 and 1819 packs that we produced. Then I'm going to cover just a bit of an overview of the data sources. We cover how the packs are produced, and then where and how to access the packs. And also we're hoping to do a second version of the 1920 packs. So I'm just going to go through the additional bits of information that are going to be going into that version too. And then afterwards we can go into questions and discussion. So just a bit of an introduction and background behind the PCM packs. So before the PCM packs, RightCare produced practice level packs for key programs and conditions. So we did these for CVD, respiratory cancer, and also MSK and GI as well. So this was done a few years ago at 15, 16 and 16, 17 levels. So in the team, we already had prior experience dealing with practice level data. And then in early 2019, we were commissioned by the Primary Care Directorate to develop PCM packs. So throughout 2019, we produced prototypes of the packs for emerging ICSs and used feedback throughout the year to continue the development of the packs. And then I organised a workshop that took place in September 2019, where a range of stakeholders from all regions attended. And we gathered loads of feedback from that, and again, made improvements to the pack based off that feedback. So the PCM packs are roughly based on a RightCare Where to Look pack that's previously been produced at CCG and STP level. But we also include the distribution charts that if you're familiar with any CCG level focus packs that are included in there. So they're kind of a bit of a hybrid between the two packs. So we cover the 10 main program areas, how the Where to Look packs do, but we've also got kind of the more granular level detail with the distribution charts in there also. So 1718 and 1819 packs were produced using practice level benchmarking due to PCM mapping still being developed at the time. So since doing the 1920 packs, the PCM mapping is become available. So we've updated this methodology to benchmark directly at PCM level. I'll go into a bit more detail on that later on in the presentation. And just generally, the purpose of these packs is to help identify potential opportunities for improvement at PCN level by comparing to similar PCNs. But as with anything, local interpretation should also be taken into account when viewing these packs. So just to start us off, so the first chart that you come across in the packs is the headline opportunities. So I'll just quickly is the so I've got a example pack up here. So Whitfield PCM, which is in Stoke-on-Trent. So to start with, in the pack, we just have a bit of an introduction on what primary care networks are, the benchmarking methodology. We've also added some interpretation charts in now to help interpret the different charts that are in the packs, which are new to the version 2. So hopefully that should help as well when viewing the packs. And then we've got some information on populations as well. So the first chart that you come across in the pack is this headline opportunities here. So if I just flip back to my presentation. So the headline opportunities pull through the top 5 programmes based off the activity equivalent of spend opportunity. So essentially, out of the 10 programmes that we look at, the highest opportunities are pulled through and the corresponding programmes are selected as the top 5. So it aims just to give users a starting point in terms of what programmes there's potentially high opportunities. So it's worth noting that we don't present spend and activity data for mental health and dementia. So if there are any quality measure indicators for this programme area, the programme's automatically put into the table just to avoid it being dismissed. So then, along with the activity opportunity, we also present the spend opportunity, and then we also have up to the 3 largest quality measure opportunities for the 5 programmes that are pulled through. So it's just meant to give kind of a high level kind of idea of where there's some high opportunities for the PCN amongst the programmes where there's high activity opportunities, just to kind of give a starting point. So I will just quickly flip back to the packs. So as well, quite a useful kind of function of these is these indicators are hyperlinked. So you can click on those and it will take you to the distribution chart for that indicator. So you can see where your PCN sits amongst the national distribution, and it's similar 20 in that chart as well. And the same for the spend indicators. So again, they're hyperlinked, so you can jump to those charts just to make navigation a little bit easier because they are very large packs. Also, it's worth noting that so we don't have, because the data is built from practice level, we're limited somewhat to what data we can get. So not all programmes have quality measures. So for neurology and GU, we don't have any quality measures. And then there's some where there's only one. So for example, MSK, there's only one, and the one that we have doesn't have an opportunity for this PCN. But there is a note that comes up. So it's still kind of, you should be looking at this programme, but because we're limited to what data we can get, we also have kind of a list of intelligence resources here for like further on like national priorities to kind of give you an idea of what you could potentially be looking at. And for specifically GU, we've got a UTI section, so we've added a hyperlink there again, which will take you to the UTI section, and it's got some more information there on that. So I'll just go back to here. So, and then the only other thing to mention on that is that the opportunities that are presented here are to the lowest or highest 10 rather than the similar 20, unless the indicator's benchmark is to the similar 20. So the next charts that we see in the packs are the opportunity charts or red-blue charts. And so these present indicators in certain sections, so cancer quality measures, primary care prescribing, spend, bed days, and they present how the opportunities are made up of the similar 20 PCN opportunities and the best or lowest highest 10 PCN opportunities. So the blue bar represents the opportunity calculated if you were to compare your PCN to the average of the similar 20. If there's no blue bar, then there isn't a significant opportunity when compared to this benchmark. And then the red bar represents the opportunity that is calculated if you were to compare your PCN to the average of the best or lowest or highest 10 of the similar 20. So it's important to know that if an indicator has both a blue bar and a red bar, then the similar 10 opportunity is the combination of these two bars. So this is the similar 20 opportunity, and then the bit in red is the additional opportunity to reach the best 10 benchmark. But in the column at the end, this gives the total best 10 opportunity, but this is just a sum of the two bars. So for the spend on admission charts, we, as well as the spend difference, we also have an activity equivalent opportunity, which is included there. So what these charts do is allow you to compare indicators within the same sections to help identify which indicators have the highest opportunities. And you can also see the split of the opportunities, how they're made up of the similar 20 opportunity and then the best 10 opportunity as well. So I'll just quickly show you this section in the packs. So we have risk factors, some information on GP patient survey, so satisfaction of service in GPs, then detection, then kind of all the quality measures for each of the programme areas, so cancer, endocrine, CVD, respiratory, so all the information that we are able to get for those. Then primary care prescribing for all the different programme areas, spend, so total, elective, non-elective, and then bed days, the same, total, elective and non-elective. So after that, we then have the pathways on a page. So these pull together indicators within a programme or clinical area to show how the PCN is performing compared to its similar 20 across the whole pathway. So prevalence, quality measures, prescribing, spend. So this should help identify specific programme areas where PCN either needs to improve overall or alternatively performs well within a programme area. So the way these charts should be interpreted are, so if the bar is green, that means that they're performing better than their similar 10. If the bar is red, they're performing worse. And then if the bar is blue, then that means it needs local interpretation. But you can still, from the chart, identify whether your PCN is performing lower or higher, dependent on whether they're above or below the 0 on the y-axis. In some cases, there might be no data on the chart. That just means we don't have any data for that PCN for that indicator. And then what's also useful with these charts is you can use the confidence intervals to determine whether the difference is significant or not. So if that confidence interval crosses the 0 on the y-axis, that means it's not statistically significantly different. If it doesn't cross, then it's statistically significantly different. So again, I'll just quickly show you what this looks like in the pack. So again, we just cover all the different pathways for the programmes that we cover in the pack. So next is something that is different from the packs that you'll currently have access to. So in the packs that you'll currently have, we included some COVID recovery STP distribution charts. We still have those in the pack, but we've just adjusted the pack slightly. So those charts aren't at the start of the pack anymore. They're further down. I'll go into a bit more detail when I get onto those charts. But instead, what we've got at the start is just this summary table for total bed days. And it essentially just summarises the data for all programmes and also compares it to the standard indicator. So the first two data columns, so the COVID recovery value and the COVID recovery STP average, gives a summary across each of the programme programmes, and is comparing the percent of bed days for 2021 Q2 versus 2019-20 Q2 between your PCN and the STP average. And then we also, like I said, we also include the value, benchmark, and the opportunity for the standard indicator equivalent. And then again, similar to the headline opportunity table at the beginning, the values on these are hyperlinked, so you can jump to the charts. So this is the cancer total bed days COVID recovery chart, and you can then also flick to the standard indicator. So again, it just makes navigation a little easier when going through these large packs. Then we've got the COVID recovery charts. So the COVID recovery indicators show the measure as a percentage comparing 2020-21 Q2 versus 2019-20 Q2, so pre-COVID baseline. And this is, we present these for total elective and non-elective for bed days and spend on admissions. So the PCN is shown in a distribution of the PCNs within the same STP. So you can see where your PCN sits within the STP, and your PCN is highlighted in yellow, and the similar 20 PCNs that are within this STP are highlighted in grey. We've also added some data labels for version 2, just so you can get that information from the charts as well. So as I said, these graphs were originally placed at the start of the packs. However, we've decided to display these alongside the standard indicator equivalents, so for easier comparison between those indicators. And then we've, as I mentioned in the previous slide, we've included that summary table at the start. So we still get a summary of the COVID data, but without kind of a load of graphs right at the beginning. We can come, so then you can come to that along with the standard equivalent indicators. So
can I jump in just to make sure?
Yeah, of course.
Chart, right. So that, can you go to that chart? So that's showing this primary care network only has about 57% of their cancer bed day activity compared to pre-COVID.
That's
whereas their peer on the far right, South Stoke West, is a similar demographic. So it's the same cluster in the same area, has done 130%, so more than the way before.
Yeah, that's correct. Yeah.
Interesting.
Yeah, that's
okay.
exactly how you should interpret these charts. Yeah.
Wow. Okay, thank you.
So yeah, let me just go to the charts. So yes, I'll show you how they're placed. So they're placed at the end where the spend and bed days distribution charts are placed, but they're just displayed with the corresponding sections. So this is the COVID recovery total spend ones. So you've got all the ones for the different programs. And then in the next section, you've got the total spend on admissions, standard distribution charts. So just by having the sections side by side, it just kind of like I said, allows for easier comparison between those charts. So,
Hi, Holly. We've still got questions on those on that chart. Was that all PCNs within the STP, or was that all the peers of that PCN on that previous the COVID recovery?
Sorry, are you okay? Just to repeat that, I didn't quite catch that.
So the PCN is showing distribution of PCNs within the same STP. So okay, so that's within that.
Yes.
And then the highlight, the grey ones are ones that are in the same cluster.
Same.
Got it.
Yes.
I got it wrong around. Cool. Okay.
Yeah, that's right. Yes. So all of those PCNs on that chart are the same PCNs within the STP. The yellow one is your PCN, and then the grey ones are PCNs in the same STP, but also within that PCN similar 20 peers. So you might get charts where there's no grey PCNs because none of their peers are in the same STP. It'll range from PCN to PCN. So the next set of charts are the distribution charts. So there's two charts on the style of graphs. So we have the national distribution charts. So again, this shows where your PCN sits, and that's highlighted in yellow. And the similar 20 are highlighted in grey. So we've also included a label and an arrow to demonstrate where your PCN sits. So we've tried to replicate what's done at CCG level with the national distribution charts, but obviously there's a lot more PCNs than what there are CCGs. So we've just tried to make sure that that's visible for people to see where your PCN sits. And then underneath that is the similar 20 distribution chart, which again shows where your PCN sits amongst its similar 20 PCNs. There's also, on the national distribution chart, there's a national average line, so you can see how your PCN compares to that. And again, a benchmark line, so for this indicator, it's the lowest 10 average, and you can see where your PCN sits compared to that. And similar to the pathways on a page, you can use the confidence intervals to determine if it's significantly different. Obviously, it's indicated in the opportunity box as well. But so if this confidence interval crosses the benchmark line, then it's not statistically significant. If it doesn't, then it's statistically significant. And we don't present opportunities compared to national, but you can use the same logic for the national chart to kind of have in your mind whether you're significantly different from the national average as well. So then also included on this chart is the opportunity box in the bottom right hand corner. So this presents an opportunity and the unit associated with the indicator that the PCN would need to change by to perform at its benchmark value. So this is indicated by a red, so worse, green, better, amber, not statistically significant, or blue, needs local interpretation background. So for these charts, we have them for most of the indicators that we've got in the packs, and they make up the majority of the packs. There's quite a lot in there, but hopefully you should be able to use the information that you go through before you reach these charts to kind of have an idea of which areas you want to look at most. That's kind of why they're placed after everything else. So we have some, again, kind of follows the same indicators that we have in the previous chart styles. So risk factors, and then GP patient survey, and then all the quality indicators, which are mainly QoF based. We have a few other indicators in there, but I'll kind of briefly touch on that when I go through the data that's covered in the packs. And then we've got the primary care prescribing, and then it goes into the COVID recovery and the standard spend and bed days. So for total, elective and non-elective. So I won't go through all of them because there is hundreds of these graphs. But yeah, what we've also included for the second version is a subheading for each indicator, just to help navigation a bit easier as well. So that kind of covers the main charts that we've got in the main PCN packs. We do also have some additional tables and charts. So we have some frailty data tables. So these are summary data tables for GMS contract data and polypharmacy data. So for these, data is shown at practice level, as well as showing the overall PCN value at the bottom of the table. So opportunities aren't appropriate to calculate for these indicators. So we've decided to present the data in a table format, and you can also compare across the indicators as well. So it just kind of keeps everything in one place and makes comparisons across indicators a lot easier. So these are at the start in the frailty section. There's also some narrative in there which will help interpretation of the data, and then some polypharmacy data narrative as well for the polypharmacy data table. We also have a couple of data tables around mental health. So this is on people with a diagnosis of dementia. So again, data is presented at practice level, but then we also have an overall PCN value in the table. Again, opportunities are appropriate to calculate. So what we've done is we've added in the national value, just so some level of comparison can be made against the national and see how you compare against all PCNs. So these are within the mental health quality measures section. Here we go. So they're just the two data tables there at the end of the mental health quality measures section. I briefly touched on the UTI section earlier, but yeah, so we have a lower UTI antibiotic prescribing section within the packs as well. So we've got two ways of presenting data here. So we've got a table that compares the different measures for antibiotic prescribing for lower UTI. So we've got the total combined and then two different specific types of antibiotics. Again, data is shown at practice level to show the breakdown of the practices within the PCM. What we've also done is we've applied a gradient formatting. So the darker the colour means the more prescribing. So at first glance, you're able to kind of get an idea which practices are prescribing more in this area. And then we've also got a scatter plot which compares total combined antibiotic prescribing for people aged 70 plus and nitrofurantoin prescribing aged 70 plus, and your PCN is highlighted in yellow, similar 20 in orange, and then the rest of the PCNs in blue, so you can see where your PCN sits in that scatter plot. So again, this is in the GU section and under urinary tract infections. There's also some narrative here. Again, really useful to help interpret these this table and this chart. There's a bit about kind of resistance on certain drugs, so that helps kind of indicate to help kind of understand which drugs should be prescribed over others. So that's really useful information when looking at these charts here. And then following that, there's the distribution charts around the same area. So the combined antibiotic and then the nitrofurantoin, trimethoprim, and so on. And then the final additional table that we've got in there is just some information on proton pump inhibitors. So again, this is shown at practice level and is mainly looking at the number of unique identified patients in particular. Again, this just allows comparisons to be made across the different indicators associated with this. So this is in the primary care prescribing section. And again, has some narrative, again, to help interpret the data, the data table that I've just shown in the presentation, and again, the distribution charts for the indicators related to that information. So the only additional thing worth noting for the PCM packs is the annex that we've got in there. So we have included a list of practices that in your PCN, as well as details for your PCN, so which CCG, SDP and region they map to, and also that same information for the similar 20 for your PCN. Next, we have the CCG summary packs. So again, for these packs, we've included the same information at the start, just explaining what PCN is, the benchmarking and the populations we use within the data. And then we have this headline opportunities chart. So this relates and corresponds to the headline opportunities table at the beginning of the PCN packs. So it pulls information from this table here. So what it is it's a count of how many PCNs within your CCG. We've also added how many PCNs are in your CCG in the key there. Have the programme areas listed in their top 5 headline opportunities. So then this kind of gives an overall ranking of programmes with the highest opportunities or potential opportunities for all the PCNs within your CCG. And then the other chart that we have in the CCG summary packs are these pathways on a page tables. So these tables are made up of the same information that goes into the pathways on a page charts in the individual PCN packs. So the kind of additional benefit of these tables is you are able to then compare all the PCNs within your CCG and how they perform across each of the pathways. And kind of when you hover, I'll demonstrate, when you hover over the grids, it also gives you a bit more information on the PCN. So I will demonstrate that. So if you hover over, it will just give you information about that specific PCN and indicator. So it'll give you what the PCN value is, what the benchmark is, so the similar 20 value, and if there is an opportunity, what the opportunity is. It also tells you whether it's significant or not. But there is a key here to help interpret what the different symbols on the chart means, but it's fairly easy to interpret. So let me quickly go to the pathway on a page for this. So it is exactly just the same information. So here we can see it's significantly higher in blue, significantly higher in blue, red and significant, red and significant, green and significant, green and significant, non-significant, lower red, non-significant, lower red with the arrow pointing down. So it's just presenting that information in this format. So you are able then to compare across all the other PCNs that are within that CCG. So for example, this one for Whitfield, all other PCNs are performing quite well on this screening indicator. However, Whitfield isn't, so that will probably be something worth exploring for that PCN. So yeah, it just kind of gives you loads of information for all the different PCNs within your CCG. So then we have the SDP summary packs. Again, with the SDP summary packs, we have the same introductory information. And then we have this headline opportunities chart again. So it works in a similar way to what the CCG chart does, but it is split out by the CCGs within the SDP rather than a total sum of PCNs within the SDP, just to break down the information a little bit. But if you sum all these numbers, you'd get a sum of the PCNs that have that programme listed in their top 5 headline opportunities for the PCNs within your SDP. So again, this kind of gives an overall ranking of the programmes with the highest potential opportunities for all the PCNs within your SDP, but it's just scoping it out wider to the SDP rather than the CCG. And then the only other bit of information in the SDP summary packs is this executive summary. So it's meant to be just a very high level overview of some of the highest quality measure opportunities for PCNs within your STP. So what it does is it pulls out the top 3 programmes from the STP headline opportunities chart. So these top 3 here. And but it's also worth noting as well, so for, as I mentioned when I went through the headline opportunities in the PCN packs, so neurology and GU, we don't have any quality measures for, so if they are in the top 3, then it skips to the next programme, because there's no quality measures to show. So we want to show as much information as we can while still keeping it high level. So it would just skip to the next programme. So then within each of these 3 programmes, the 3 highest aggregated opportunities for all quality measure indicators are selected. So then these opportunities are a sum of the PCN level opportunities aggregated to STP level. Like I said, this is just to provide users with a handful of indicators where potential improvements could be made for PCNs within their STP. So just to kind of go through the differences between the packs, what kind of the purpose of each pack is and how to link them. So when we first produced the PCN packs in 2019, we originally planned to just do the main PCN packs. But as I mentioned, we had a workshop in September 2019, and one of the main pieces of feedback we received from this workshop was that the packs needed some form of summary where you could also compare PCNs within the same area. And additionally, we got feedback that the packs were too big for someone who might just want a high level information. So from this feedback, it was discussed that we could produce smaller summary packs at both CCG and STP level, which would also stretch out to more audiences. So each pack has a slightly different purpose to it. So the STP summary pack, so we designed this in mind to keep it very brief and keep it very high level. So we just wanted a 2-page overview of which quality measures have high opportunities for PCNs in that STP, and then an overall which programmes have potentially higher opportunities from that headline opportunities chart. So then from this, people would have an idea of which areas they need to focus on more, as well as give some example indicators where there was high opportunities, instead of having to go through the large PCN pack and pick out things individually. Then for the CCG summary pack, we also want to keep it fairly small, but kind of give a bit more detail than what was given in the STP summary pack. Again, it gives an idea of what the higher priority programmes potentially are within the PCNs in your CCG, and you can then focus more on these pathway tables first in the packs, because even though the packs are a lot more concise than the PCN packs, there's still quite a lot of information to digest in those pathways on a page tables. And so kind of having a look at the headline opportunities chart kind of might give you an idea of which pathways on the page tables to start looking at first. So kind of the main thing about this pack that you don't get with the other packs is it kind of gives you an idea of the variation between the PCNs in your CCG, and see if there's any specific indicators within a programme pathway where PCNs are performing particularly worse, better than their similar 20 peers. So what you can also do as well is compare the programme rankings between the CCG and STP summary packs to see how this differs when you span out to the whole STP. So you can compare that headline opportunities chart to see how the programmes are ranked and how different that is when you compare this, when you look at the CCG and the STP. And then the PCN packs, so obviously these are a lot more detail, but what you can do is you can use the STP and some CCG summary packs first to try and give you an idea of which programme areas are best to focus on, and should give you an idea of which areas in the pack you might want to look at first, given that it is such a huge pack. What you can do is you can use this information and then the PCN's individual headline opportunities to do that. So with the PCN pack, you can drill down to a more individual level for the PCN and see where your PCN sits in comparison to all PCNs and their similar 20. so with the distribution charts. You can also have a look whether there's similar patterns within the pre-packs, and then you could potentially take from that your PCN is performing similarly to other PCNs in your CCG or STP. Or, however, if the PCN packs draw different conclusions, then that might be something worth investigating and exploring why they perform differently to other PCNs within the same area. So I think the packs can be used singularly on their own, depending on what your wants are from them. If you don't have a lot of time and you just want to have an idea of a couple of indicators, then you can use the STP summary packs. If you're wanting to just have an idea of how your PCN compares to other CCGs, then obviously the CCG summary packs are really useful for that. But then also if you want in kind of the individual PCN level detail, then you can find that in the PCN packs, but also kind of using them all together to kind of narrow down which areas you want to look at. That's also something you can do with all 3 packs. So moving on to the differences between the 1920 packs and the 1718 and 1819 packs. So as I mentioned before, for the 1718 and the 1819 packs, we did benchmarking at practice level for these and aggregated opportunities to PCN level. So as I mentioned, the PCN mapping wasn't available, and by the time the PCN mapping would be available, it would have taken a longer time to then refresh everything and do PCN level benchmarking. And the packs were in high demand. So that's the route that we decided to go down with those packs. But given that when we started the 1920 packs, mapping was available, we decided to aggregate data to PCN level and directly benchmark at PCN level going forward, given that they are PCN level packs. So the methodology behind this benchmarking is exactly the same methodology that we use at CCG level. So we use the same variables, the same calculations. So it's consistent between the RightCare products. In terms of data and how we present it, so due to the change in methodology, this also meant that we had to change how we presented the data. So in the previous packs, the data was presented at practice level for the practices within the PCN. For the majority of the information now, we present that at PCN level. So we have still, though, produced data at practice level to create the PCN level data, because not all sources have, I think more have PCN level data available now, but when we first started doing these, it was still practice level. So we still have all the practice level data, and then as I've demonstrated, we still have some data tables within the packs that are presented at practice level. In terms of the indicators, so most of the indicators we cover in the packs have stayed the same. There are a few additions where we've scoped out a little bit more, but the main addition is the COVID recovery indicators. And then in terms of the charts, if you're familiar with the previous packs, you'll have noticed as I've gone through this, that the charts within the packs have changed quite significantly. So given we've changed the methodology to that's similar to the CCG level, we've now reflect the charts within there similar to what's included in the CCG level products. So it again allows for consistency between our different packs, but as well, a lot of the information we displayed before were in table format rather than graph format. So I think the information now is a bit easier to digest as well, and is a better way to display the information. A quick overview of the data sources that we cover. So we include spend, bed days, and COVID recovery, and this is all got from secondary user service, so through NCDR. We also have primary care prescribing in there, so this is all extracted from the BSA or the EPAT2 dashboard. We have all the quality, all the QoF indicators in there, and that covers most of the quality measures that we cover in the pack. but we also have some additional indicators, so some information on GP contract data and people with a diagnosis of dementia from NHS Digital, and then some additional indicators from fingertips, so prevalence, cancer screening, and GP patient survey. Just a quick overview of how the packs are produced. Like I said, sorry, yes.
Before we go on, is it possible to pause and ask some questions?
Yeah,
keep through and ask questions aside after that. Nigat, you kind of came back quite a while ago with a question on bed days and length of stay, and why did we pick the length of stay indicator? What a bed days indicator is the length of stay.
Sorry, I didn't quite catch that. What was that?
Sorry, I'm a bit I'm not sure what it's. Could you just come in? I'll ask the questions and then I can feed him back for you.
I'll put it on.
Sorry. Is that better? Yeah, no, okay. Sorry, Holly. We've got to do the response. So Nigat asked some questions about the bed days indicator and why we've chose that and why we didn't use length of stay. And I think that my understanding of that is we're looking for an impression of the total use of resources within a system. So length of stay isn't necessarily the most reliable one because you can soon have an outlier that can skew kind of the averages on there. It's difficult to use the mean or median, some complexities on that one. And model health system probably has a lot more of that kind of broken down by provider and speciality. It's probably a bit more useful. My kind of impression is we use the total bed days as an indicator of the total volume of hospital care used. Is there anything else you wanted to kind of say on that, Holly, or Jenny?
Yeah, well, I think that pretty much covers it. Yeah, we kind of use the bed days as kind of almost an admissions measure, and also because we're looking at smaller areas as well, kind of more granular level detail, we can get quite small numbers, so in terms of the data available as well. But yeah, I think your response kind of covers why.
We had some. Thanks, Holly. We had some questions on local interpretation. So Charlotte, you're asking is difficulty of working with those. Charlotte, do you want to come in and say any more on those ones? Because we're putting things there like spend on cancer, things like that being as for local interpretation, because there's no good or bad answer on that one. If you've got high prevalence of cancer, you want to have high volumes of treatment. It's generally the kind of impression of those indicators. Was there any particular concerns you had with that issue? Do you want to come in, or?
It was just really about how you determine what's open to local interpretation and how you get to that point. I think because we know that, we've been saying in the chat that it is very dependent on when you look at the local interpretation of your spend versus your activity, etc. And you'll see, maybe you have like high prescribing costs with regards to statins or cardiac medication, but actually it's more of a quality initiative locally. And actually, although your prescribing is higher, your actual number of people that are having strokes, they're more, well maintained, etc. So as a PCN and a CCG, you can justify that. So, but it's about understanding what is local interpretation, because I know earlier on I said it was a bit of a red herring, but if you have your top 5 priorities and 3 of those are locally interpreted, and actually you can justify the 3 of those as to reasons why you wouldn't make any significant changes in the short term, that leaves you with 2 other priorities to move forward with. So it's just about how you manage that.
It's really hard, and I kind of empathise with the national colleagues who had to produce these things and try and work out a way of automating something that works for 1,200 primary care networks. It's kind of impossible to have everything that works for every possibility. But Miles, do you want to come in on kind of how you do some of this locally with systems? I see your hand up.
Yeah, no, I heard Charlotte's point quite clearly there, really, and I take your point that if you're only producing 5 and 3 of them are, I won't call them red herring, I understand what you mean now, that 3 of them are not going to help because they explain a variation which is intended, or they highlight a variation that's intended, then yeah, you would only have sort of 2 left in your list. But there's a big pack, and what I'd suggest is that you look at it with your improvement, your system improvement partner or whoever, and you look, because all the rest of the details will be in that pack. It's just that that pack is only automated picking out the biggest 5. But I mean, you Alex, I completely agree with when we said that. So, for example, situations where I think you use the best example there: high statin prescribing, high spend, and it then produces much lower non-elective events, that sort of thing. So, high spend, good reason, and therefore it tends to get coded blue for interpret this locally as to whether it's where you want to be or not. The reds are kind of those areas where you look at and you think, no, that definitely can't be right. Too many non-elective admissions, too much non-elective spend, those sorts of things are always going to be red. But we've tended to sort of leave it for clinical judgment and local judgment when they're blue.
Thanks, Mark.
It has really helped. I mean, we've used them locally, the PCN data packs, but it's then triangulating it with other data sources like your public health data, your fingertips, your shape tools. And actually, that's when you could start to see common themes that actually kind of give evidence to the argument. So it's about being able to make sure that this is one set of data and how you utilise that with other areas of data that you can use.
Yeah, absolutely right. It's never going to answer all the questions, but hopefully it just kind of gives another steer and point in the right direction. Perfect, the intention. So thank you. Sure, that's really helpful. There's a question about the practice level breakdown. So I hadn't realised we'd lost some of the practice level tables we had in previous ones. So that's good to see. So I understand now more about why that's come about. I think it was Craig who was asking that question. So now for some of the indicators, we get that detailed practice breakdown that lets you see whether practices stand out, but you don't get it for all the indicators now. So we don't get it for the spend and activity. Is that right, Harley?
Yes, that's right, because we've kind of moved more towards presenting stuff at PCN level. However, we do have all the practice level information. So if people wanted some specific practice level data, we do have that, and we can provide that to you, Alex, and you can share that locally.
Great. So if we come to us, we'll share that. We'll work out that.
Yeah, absolutely.
We've got some ways of cutting that down. So yeah, very helpful.
Yeah, I think so. The idea is obviously they're quite big packs anyway. There's only so much detail we can have in there. And when we had the previous packs, when it was broken down at practice level, we got a lot of feedback asking why it wasn't at PCN level, and given that PCN mapping wasn't finalised, that's why we couldn't present it at that level at that time. So given the PCN packs, it made more sense to present stuff at PCN level and do direct PCN benchmarking. But yes, we do have that practice level breakdown, so we can provide that level of detail.
The final kind of question, and then we'll come back to the practice stuff, is comparison over time. So somebody else, I forgot who it was, so I didn't catch the name, but somebody asked, can we show change over time in some of these indicators? And I think I responded on the message. I think there's some caution with doing that approach, using the packs to do it, because what we end up doing, I think as Holly described, is we change the method subtly each year. So you end up with different PCN groupings, different comparators, perhaps slightly different measures and methods. So it's not always a reliable kind of comparison year on year to do that. So do you want to say anything else on that, Holly?
Yeah, that's exactly. Yeah, I can agree completely with that, because some of the method, I mean, obviously the packs this time have changed quite significantly in terms of the change of benchmarking. So that wouldn't be able to be compared to previous year. Going forward, if we stick with the same benchmarking, obviously it's more like similar than what it is now compared to previous packs. But like you said, we still update the PCN similar 20 each time. So in terms of comparing that, there's differences there. I think there will be available resources for stuff like time series elsewhere, though. If you've got access to EPAC2, they have PCN level stuff on there now on their dashboards, and I think there's some time series information on there. I think there's a PCN report on Viewpoint as well. So there is other places that you can kind of source.
I'd say if you want to get in touch with me direct in the region, we can probably look at how we can share with with local data or kind of point to the definitions. We've got all the code that's used by the national team to produce these. I think we're going to get onto some of that as well. So if you want to kind of implement it locally, you can do. Just kind of create a similar metric. We use fingertips a lot to do this kind of comparison, particularly for the quality measures, because you get the practice drill down and the trend over time, then where they're comparable. Yeah, I'm happy to help out with kind of the admission kind of rates and changes. That's kind of where we're from. Miles, did you have a new hand?
Yeah, no, it was a new hand, and it was probably Holly might shoot me for this, but it was a general question about, well, in the past as RightCare, we always used to compare with a similar 10 CCGs. That's when there were about 200 of them, so about 5%. I just wonder whether comparing with a similar 20 is the right number. I'm sure it's that the packs are fantastic. They're absolutely wonderful. But I wonder what the thought process was at deciding, well, let's compare with a similar 20. I was thinking, if it was parallel to the CCGs, and I've got my mental arithmetic right, it would be similar 50. And then you could always guarantee that there'd be some local ones and some ones who could share. So it's not a request, please, but it's a thought as to how we got there.
Yeah, so we did some analysis on what would be the best sized peer group to compare to. So we had a look at a couple of indicators comparing different years of data and kind of use it. So we had a look at peer groups ranging from 10 to 25. We didn't go as high as 50. I think we kind of thought any more than 25 is then comparing to that many peers going to be unmanageable. But we've got all the analysis, so if you were interested in seeing what the results were from adding on extra peers, and we also we looked at kind of how data and benchmarks changed and kind of the similar 20, kind of there was smaller differences with that peer group size compared to other peer groups. We also had a look at how many PCNs will be in the same region. So again, out of all the peer groups we looked at, the similar 20 came out quite well there, where there was only, I think, a small amount of PCNs, where there were no PCNs within the same region. And we also had a look at the difference in population size compared to the peer groups and that PCN. And again, I think it was like on average like a 1% difference between the PCN and the peer group size. So we did various tests to make sure that it was a good kind of choice in terms of peer group size. But yeah, we're always looking to kind of develop. So if there was like a bigger peer group size that you wanted to look at, that's something we can always look into. But we thought it was still a manageable peer group size for people to compare to, but kind of still giving people a good amount to compare to as well, not just a small group where actually any of those PCNs anywhere near them locally or so on and so forth.
Are we going to come back to the similar method? Is that on the slides coming forward?
So kind of how we produce.
Yeah, the kind of peer groups and deprivation, rurality and all that.
So I don't think I've actually covered peer groups, but I'm happy to discuss that after.
We just had a question from Charlotte. So I think yes, the peer groups from what we do is it's based on the size of the practice, it's based on the deprivation scores, it's based on rurality, ethnicity. There's the 4 ethnicity categories, I think, and
rural urban population as well.
Yeah.
So it's based on all of those. We add different weightings. So deprivation has like a 25% weighting on all those different demographics. But yeah, and then what we do is we do the sum of squared difference and then kind of get like a distance matrix for how kind of different or similar each PCN is compared to the other, and then based on that we rank what the closest to furthest away PCN is for each PCN. So it's exactly what we do for the CCG level, it's just with PCN level data.
I think I've missed 2 questions. So one was on access to the pack. So I'm sure you'll get to access to the pack.
Yes.
Now we're coming to it and emailing you, so I'm not going to mention that one. And the second one was from Connor. Does it include IIF data? I know what IIF data is, such as social prescribing referrals, GPAD. I think what we're limited in what we can do is things that we can collect nationally from practice data sets, but are those things we could grab nationally? I'm kind of, is anything you want to tell us about those data sets? Invest and Impact Fund. Not very familiar.
Yeah, Invest and Impact Fund. I think it's that. It's a national contract, national PCN contract. So it's flus. It's a flu uptake for over 65s. It's GPAD data, social prescribing referrals, and there was some medication was in there last year, but they are picked up on the PCN national dashboard. So it's just whether if you're trying to get a lot of things in the same place. It's probably going to be quite useful as well because it's something that will be assessed upon.
It's something I'm sure we can look into.
Yeah, definitely. We are trying to kind of link up a bit with the PCN dashboard as well. So we're always trying to scope out for more data to include. So yeah, that's something we're actually currently trying to look into, whether it will be able to implement it into the second version of these packs or not, or whether it'll be something for 2020-21 packs. But yeah.
Thank you. Right, I'll stop there. That's an amazing shed con. I'm impressed. Right, I'm going to stop there and let you carry on, Holly, and let you get through some of the further content. Thank you.
Brilliant. So, yeah, the next thing that I was just going to cover was just a brief overview of how the packs are produced. So it's just kind of the very basic information. Like I said, Jenny's on the call, so if there is any more technical questions, we do have Jenny here to help with that. So historically, we've produced the packs in Microsoft Excel. We're kind of given the size of the data file for PCN level data, so it's kind of twofold. All the indicators that we include, because we're covering all the programs, and also kind of for each indicator, there's a lot more rows of data for PCN level compared to CCG level. So what we now do is produce these in our studio, and over just more generally in RightCare, we've now started producing packs in R more. It just seems to be more efficient software in terms of producing the packs. So, and then additions to this, what we've also done is we've changed from presenting the packs to from PDF to HTML format, which if you've seen the previous packs, I'm sure you will have noticed the change in format there. So how we actually produce the packs. So the data and the metadata for the indicators used in the packs are collected at general practice level. And then we use an R script to aggregate the data to the PCN level and calculate new confidence intervals, benchmarks, and opportunities. We then have three main files to produce the packs. So we've got an Excel input file, an R script, and then something called an RMD file. So the Excel input file contains the PCN level data, the metadata, additional sheets on which indicators to assign where to what kind of for the individual graphs and tables. Any narrative goes in there, how the packs are structured in terms of the order of indicators. All that information is pulled from one Excel file. Then the R script is used to filter what data is needed for a specific graph and then define the aesthetics for each of the graphs and functions. And then the RMD file defines the layout and formatting of the HTML documents. So by using R, we're better able to ensure the robustness of the packs, store and manipulate large data sets, and run packs off quicker than using alternative methods. So the run process compared to what we were running them when we were doing Excel is a lot quicker. So in terms of where and how to access the packs, so we put all the information on a platform on Future NHS. So I've added the link there, and I'm happy to circulate these slides around afterwards as well. So this workspace is currently set, so people have to request access. So the reason that I've done that and kept it as that is because there's such large packs and there's a lot of information there. It is advised that some form of guidance is had before using them. So if people have had some level of guidance from their regions or elsewhere, I'm more than happy to grant access. So you can do this by either doing it through the workspace, or I'm more than happy for people to drop me an email and I'll send invites out. So on this workspace, there's kind of summaries of what the packs are, but also I have all the previous packs on there, as well as kind of if we make any updates, then I broadcast that to all the members of the workspace, so all information is filtered through this workspace. And then in terms of future versions of the packs, so as I said, we plan to do a second version and hopefully soon. So in here, there's going to be annotated graphs to help interpret the charts, which I've already kind of shown at the beginning of the presentation. We've also restructured the COVID recovery section and the inclusion of the COVID recovery summary table, again, that I've shown earlier in the presentation. We're also going to be updating the COVID recovery to Q3. Then for some of the SUS, so bed days and spend and primary care prescribing confidence intervals, we have recalculated those slightly to link bed days and cost and items and net ingredient costs for prescribing. So the data and opportunities won't change for this. It might just affect if an opportunity is significant or not. So when the new packs are available, it's just worth bearing that in mind. We're also going to be adding some additional antibiotic UTI measures into that urinary tract infection section that we've got for GU. And then there's just some minor formatting changes. Like I said, we're also trying to link up with the PCN dashboard, but whether any of those changes will be implemented in this second version or not, I'm not sure of yet. And yeah, that's it in terms of the presentation. So if there's any further questions, more than happy to go through those.
Thank you, Holly. I see if anybody wants to kind of raise their hands, ask any more questions while we've got Holly and Jennifer on the line. I think we might have already covered them, so I think we're intervening too soon. Miles, Miles and Connor. Miles first. I know you wanted to kind of share some good practice examples of where we've used this in systems, so maybe we can introduce some of that stuff and I'll leave you to ask questions.
It was a comment, really, more than a question. Certainly, when my job title was still RightCare delivery partner, and these first came out, I mean, stunning amounts of data and PCNs that were very new to the world, and took one look and went, help, and then along came COVID, and we turned our minds to different things. From what I've seen of PCNs in the parts of the country that I'm working in now, they are far more mature organisations ready for this stuff. And I had somebody in Shropshire coming to me to say, do we have any updates? Yes, you asked at exactly the right time. Here's your update. Here's your PCN. But I think it was, I'm trying to remember what Connor's question was, but it was along the lines of, how can we best use these? And I think, and my previous life was as a finance director, chief finance officer in Derbyshire, and a RightCare pack used to land on my desk every night. Actually, theoretically, it came through the email, but it sort of landed on my desk every year. And I'd open it, I go, wow, there's some good stuff in here. Haven't got time. Put it over here and I'll come back later. By the time I came back later, another 6 inches of stuff was on top of it, and I never went back. And it is that bit about, well, actually, who've you got to help you? Who've you got? There is an improvement team within NHS Midlands. Most of us RightCare delivery partners are still around with a new name type system improvement partners, as well as the GIRFT people and the OPROD people, and we're there to assist and look at data and wave things at you and go, have you seen this? And really, that's, I'd say, don't be a stranger to your local. We can put you in contact with whoever is linked to your particular patch. Certainly in the Midlands, I know less well how it works outside the Midlands now, but I think it is that thing about using others and using others to help you to drill down and find which bits of the data are most useful to you and your future plans.
Connor, did you want to come in?
Yeah, it is obviously directly feeding on from that, and I think it's a really good point. I think for me, it's really that joined up piece, isn't it? Because we're really good now at producing dashboards and profiles and new, just significant amounts of data that we hand over to people that have asked for them. Likewise, exactly what you've done. It's kind of like, this is the problem. And that's as far as we kind of get. And I think we almost need that joint up piece of how do we sort of fulfill that whole triangle of, data, information, is it knowledge, wisdom, decision making? And I think that's the bit that we need the support with. It's the, this is the data, this is amazing, there's so much here. And actually, like you've said with the other packs now, you've got the executive summaries and the real sort of targeted, these are your 5 main areas, regardless of local interpretation. That wasn't there, but these are your 5 main ones. How do we then work with the improvement teams and yourselves to sort of say, right, in other areas, we found that patients that were undermanaging their diabetes put this intervention in place and it worked. And it's just trying to share that sort of best practice, intervention, evidence-based way of working that really combines the sort of the data, the improvement methodology, and now you've got an intervention that actually equals a better outcome for a patient. And so it's just trying to sort of unearth if this has happened well in other areas, and if not, how do we start to sort of drive that forward? So data-driven decision making is that sort of key role we all play. But yeah, I think the data packs are amazing. Just to throw that in there as well.
But are you Leicestershire, Connor?
No, I'm Herefordshire and Worcestershire.
Herefordshire. I don't. Okay, because Kim was just putting it down. Just trying to think. Well, Nagat, is Nagat on the call? Nagat, are you still Herefordshire and Worcestershire?
I am. Yes. Thank you.
So I mean, it's just there's a biggish bunch of us, and quite a number of sort of subsets of the improvement directorate, all working on lots of different things. But we also tend to be geographically linked, so there are always those contact points for each patch.
I feel like I've thrown Nagat under the bus now, but I think maybe because I've worked with Nagat on various urgent cares for that. So maybe it's that bespoke piece, isn't it? Because we're very good at being told, that's a bit harsh, but told by NHS, this is your problem, now go and deal with it. And so if your problem is A&E attendances, that it's too high and too much of a drain on the system, you need to go and deal with that issue. And so we put all our resource and energy into that. Whereas actually, if we were really going to use the packs and notice that, okay, well, our 5 main ones are this, but actually we've got some sort of main programs that are going to start kicking off and we need to sort of focus on that, it would be out of the usual scope. And it's just whether we can sort of have that slightly more bespoke conversation of, actually, this is what we want to do, this is how we want to implement it, how do you work with us to sort of talk with our leaders to get people on board and implementing the right things.
More than happy to do that, and I think we have done that previously. The risk of starting to sound defensive, which I'm not, I think it's also about timing, and COVID hasn't helped about when we landed. And certainly for me, we've started with Emily Godfrey, who's your performance lead, looking at where we can add value with the model system and RightCare and PCN data, and we're focusing on the MEDP programme, so that's where we're using a lot of this information. But we have done that. I'm more than happy to connect again and work that through and work with the system priorities and the bespoke packs, as you've said.
Really useful. Yeah.
Thank you very much. I think kind of the questions we've had about kind of turning to place level analysis, comparing it to things like shape tool, fingertips, all the other local data, looking at practice level, PCN level, it's all part of that bigger picture, trying to break things down into, it makes sense of what you need to do and then kind of break down to the details. So comparing things alongside this, there's also the viewpoint dashboard, which is available via the NHS Tableau Analytics Hub, which starts to break things down by some different segmentations of groups, which is a really useful data source. We use the Shape Atlas lots alongside this, which kind of lets you do some mapping and kind of showing things geographically over an area and doing travel times, things like that, and inequalities analysis type stuff. But yeah, if you have any more questions around this and help, we'd be really interested in doing those really localized place-based projects with this. And we can bring Holly's team in as well if we've got a really interesting, challenging problem. They'd love to come out and kind of talk through the system stuff as well. So that was great. Some question about medicines management, Cara. I don't know if there's any medicines management people on the line. I can't recognise any names on there, but we do kind of talk to our regional medicines management colleagues on this work, and we are very cautious that we don't always want to say things are black and white on the medicines management side, because it is particularly things like your statins where we need to kind of have that improvement. So yeah, there's lots of things there. We do try and involve them both locally. We do try and link with local colleagues. Anything else quickly on the chat? NHS Benchmarking Club. So yeah, there's useful provider level data. And I think everyone's signed up for that in the country now, which is exciting. So it's another useful data set. They tend to do things that aren't part of national routine data collections a lot. There's a lot of mental health and community type stuff there. So some helps kind of build all the story together. So we can't access much of that, but you've probably got better data there locally. And Jogai, some shared contact details. So yeah, the productivity side and data that they have through Model Health System. We covered some of that on previous sessions, but again, if you need reminding of that and need help with support, please do get in touch with any of the team. We're always happy to help. Our final call for questions, I think we might be ending a bit ahead of time. Mona, is there anything else you picked up, or anything we've missed, or are we about there? You're on mute, Mona.
Oh, I'm on mute. Sorry, I've just realised I was talking. No, there's nothing that's been missed with regard to some of the questions and comments that were raised. Yeah.
So hopefully this has kind of improved your confidence, given you a bit of an oversight. But yeah, please do come to us for questions. Holly's email address, if you want to email for access, we'll sort that out as quickly as we can. It looks like we've got an issue where you can't see the contact the group's organizer if you've not got a member of the group. So we'll check into that, we'll test that out just to make sure we can see how that can be easier. But yeah, thank you all very much. One final thing, I will email out a feedback form. So if any kind of questions or feedback for us, that would be great. And we'll try and get this on video to you all to share with your friends. Thank you very much. And Holly, thank you. It's been wonderful.
No, thank you. I hope that was helpful. But more than happy for people to follow up with questions. Yeah, my email is on the presentation, which we can circle around. So yeah, if anybody's got any questions afterwards, I'm more than happy for people to drop.
Thank you very much. Thanks a lot for coming. Really appreciate it. Great to have some support.
Thanks, Holly.
Thank you.
Thank you.
Bye bye.
Bye.